Hi, Michelle.
Hello. I stepped outside for a few minutes. It was very beautiful out there.
Awesome. We do have 47 attendees on already, just FYI.
Okay.
I'm coming back tonight to work. He's like, oh, stop.
Get a spot.
Quick note, as everybody is joining, please make sure you are muting yourself.
Why isn't it popping up?
Coming too.
Quick reminder, as you're joining, please make sure to mute your line.
Oh, they kicked us off.
Yeah, because you said it wasn't a big deal.
Welcome to Zoom. Enter your meeting ID followed by pound.
Could be a long afternoon.
Did we go? Just six or. All right.
Enter your meeting ID followed by pound.
Do you want me to send this to you?
Rejoicing in
Your
life.
participant
Ask to
ID
speak with
followed
an
by
admission
pound.
specialist if you
Otherwise,
have a loved one.
please enter the meeting password followed by pound.
Quick reminder to everyone, as you're joining, please make sure to mute your line.
You are in the meeting now. There are more than 90 participants in the meeting. This meeting is being recorded. You have been put on hold by the host. You cannot listen or talk until the host releases the hold.
as you are joining, please make sure to mute your line.
In fact, oh, Margaret, I'm having this. No, I read stuff. I can't remember where I read it from, but I know that was like a recommendation, one of CMS's things.
Please make sure to mute your line.
Mute.
Residents.
Hey, it's seems like a cluster, you know what, so far, as everybody's not muted and it's just like blah, 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 but
You know what I mean? Like instead of being in this,
I'll merge it, see if it holds.
They're still 6 feet away, but they have more of a communal feeling.
Huh.
If not, we're gonna say it anyway, but I feel like.
Yeah, one of the things I know when I'm reading on resident 705, Michelle, is the fact that they're talking about several residents that in Station 2 East Hallway were not wearing a mask. They said several residents on the unit had respiratory symptoms. Now, at that point in time, you guys had West Hall, not East Hall, cordoned off with the doors being closed. Where did resident 705 reside, East or West Hall?
So what they did, John, was they mixed it all up. So
I'm going to give everyone just another minute to get signed in before we get started. Okay, I'm going to go ahead and get started. I know some people are still joining. My name is Mary Gettle. I'm the Director of Education here at the Healthcare Association of Michigan. Today, we are going to do a quick update from the department on surveys. That will take, Michelle will be speaking for around 15 to 20 minutes. And then we're going to open up for live question and answer from the audience. I see that we have about 275 attendees on right now. That's amazing. Couple of really quick housekeeping notes. I have placed everyone on mute at this time. Please remain on mute until we reach the Q&A portion of the call. And then you may unmute yourself to ask a question. We will let you know when it is time for Q&A, but please make sure that you stay on mute. Stay on mute, please, so that everyone can hear what's going on. So without further ado, I'm going to turn over the phone to Kathy Sunlin, our VP of Regulatory Affairs, for a quick introduction, and then Michelle will take over.
Hi everyone, this is Kathy at HCAM. I am really happy and excited that everybody was able to get on with us today. Just a quick introduction, Michelle Repke is joining us. Michelle is the Director of the Federal Survey and Certification Division at the Department of Licensing and Regulatory Affairs. I think many of you know her. Michelle oversees the survey teams. And her goal today is to help share some information about the infection control surveys that have been happening and going on through the state and across the nation, and share some findings with us. And then, as Mary said, she's offered to do a live question and answer at the end. So without further ado, I am going to turn it over to Michelle.
Michelle, you will need to unmute yourself.
Okay, thank you everyone, and I would like to thank you for joining us this afternoon. It's a beautiful sunny day, hope it stays this way. I also want to take a minute and thank you all for everything you're doing. It is a very crazy time. I know everyone is working their tails off to the max, and we appreciate what you do for the residents day in and day out. It's just so crazy, and it's a very hard time for everyone, and we totally understand that. It's crazy for us too, but we do want to make sure that you are aware how much you're appreciated in everything that you do. To get started, I'm going to, as you know, we've been going and doing some of the infection control surveys, and I gotta get to my screen. Okay. Zoom has taken over my screen, so I'm trying to get back to my other stuff. Okay, I'm trying, Kathy, or Mary. I have lost my screen.
Try looking down at the bottom of your screen. There you go.
Right, but I'm not sharing a screen. I'm trying to get to my.
You're sharing right now.
Oh, I don't want to share because I don't have anything to share.
Oh, here. Stop sharing. There you go.
There
now
we
you're
go.
not sharing anymore.
There we go. That's what I need. Okay, thank you everyone. What I'm gonna do is just go over some general things that our surveyors are finding. What I did is I asked the managers just to generalize. We're not gonna, it's not meant, this is not a discussion for any particular survey, any particular facility. It's just generalized findings of what we are seeing. And even today, when I was talking to the managers with the meeting, the things that we are still seeing. And I just wanted to share them so that way, some of them were like, oh, wow, I didn't think of that, one of those aha moments. So the first one is we're finding that not properly carrying out isolation procedures. And what we mean by that is the donning and doffing of PPE, staff going in and out of the unit without removing the gear. And I just talked with a manager today. So if you have a COVID positive unit, staff are, my survey staff are observing staff members that are in the COVID positive unit, leaving that unit and walking into the non-COVID positive area and not taking off the PPE. So when you leave the COVID, if you're in the COVID positive area and you want to get out of there and go to the other, you have to take off all your PPE and then leave that PPE there in the COVID area and go to the non-COVID area. But we're seeing staff, even today, going back and forth with the same PPE on. That's one thing. Another thing is hand hygiene for both staff and residents. During peri-care, feeding assistance, wound dressing changes, touching multiple residents without hand hygiene. We observed on one of our surveys, a staff member went into a room, the resident was in isolation, but they went into the resident's room to assist with feeding and they didn't have gloves on. Okay, that's one thing, not having the gloves on, but you could still do that. They fed the resident, they came out of the resident's room. Had they went and washed their hands good and thorough before going into the next resident room, that would have been acceptable. But they went right from this, feeding this resident with no gloves on, right into another resident's room to assist them. And they watched that staff member go in and out of several rooms and never washing their hands. So that's another thing. I know lack of disinfection among communal items, such as you think when you walk in and your screening staff, all of you have somebody sign in at your front door. Are you wiping that ink pen down with a sanitary wipe or a cleaner between uses? Because I know I've went into several buildings and I signed my name on the board as a visitor, but you have to remember to wipe that pen off. Another thing to think of is the glucose meters. That's one. How about the resident's lifts? After that resident's lift is used on one resident, you're going to need to clean it off so it's clean for the next resident. Another thing is all of you have bathrooms in your hallways and you always need a key to go to use the restroom. Is somebody wiping off that key because it's going through several different hands? Another thing is the vital machines, the little wheel carts that you have that you do for the temperatures and the monitoring of the vital signs. That needs to get cleaned off. Let's see. So that's that. Residents not being placed in isolation timely once the onset of respiratory symptoms begins. As soon as somebody is having some respiratory difficulties, you should probably put them, either shut their door if it's in a private room, or maybe move them to an area, cohorting them with residents that maybe you don't know their status. So you don't want to keep person that's having severe respiratory issues in a negative area when you really don't know what's going on with that resident. Lack of screening of visitors, surveyors, vendors, employees. Just recently we did a building, they had 4 entrances and all 4 entrances were being used and they were only screening the front entrance. So if you choose to have 4 entrances going on in your building, you're going to need to set up screening stations at all 4 entrances. So that's one thing. A lot of them have went to just having one main entrance, but it's important that you set up whatever areas you're using for entrances. You're going to have to set up a screening station and everybody needs to get screened. You can't just let staff go figuring they screen themselves. We need to have everybody screened. Let's see. It's very important. All of you have infection control nurses monitoring in your facilities. And we've had some instances where the infection control nurse is monitoring from afar. You know, in these kind of situations where this virus is so, runs rampant through the building, it's very important to have your infection control nursing staff on site to assist you as a building to become in compliance with all of the regulations and to help, you know, teach others on making sure they're donning and doffing and the hand hygiene. Let's see. We are finding that those facilities that work closely with the county health department have a tendency to do a little bit better as far as sharing information, and they seem to be, the infection control concerns are fewer than those that don't. So that's just a suggestion. It's not a requirement, but we are finding though, if you have a good working relationship with your county health department, you reach out to them if you have questions, things such as that we find that sharing of information helps the facility a great deal. Let's see. No social distancing. We need to remember, we went into a facility not too long ago that they had in their mind they couldn't have more than 10 people. So
In my opinion, no.
In the dining room, they had their 10 people, but they had the 10 people were all around the same table, and they were less than 6 feet apart. So it's, you know, I know we understand, and we're trying to get clarification from DHHS on this in regards to the executive order, but we understand that there are some times when you have multiple residents that need feeding assistance, and how to get around that. You know, if you had 4 tables in your dining room and all the tables are spread out more than 20 feet apart, could one person help all those residents? Well, that's a possibility, but you remember, you got to have that person's going to have to change their gloves and wash their hands in between helping each one of those residents. But just the social distancing, that is very important. Poor hand hygiene. We had in one of the facilities, they didn't have any hand sanitizer in the dispenser hanging on the wall. I understand hand sanitizer is hard to get, but they found jugs of it in another location. The facility just hadn't put it into the containers. And, you know, that's very important, is to have that hand sanitizer. So if you have it, you know, everybody's used to going to the wall to get the hand sanitizer. So that's just another thing to suggest, is if you've got containers of it, take a couple minutes and fill them all up so people that are used to going to them know that they're full and it gets used. Wearing masks. It seems to me, and I saw this the other day in Myers, and I was debating if I should correct the lady or not. She had her mask on, but we see that masks are not being worn properly. Some are below the nose, some are on the nose, or like they should be. Some are underneath the chin. We observed a Cena go into a building or into a patient's room, a resident's room, to help them, and her mask was below her chin. So the mask was just sitting there, wasn't even over her mouth or her nose. It was just sitting below her chin. So that is one thing. Make sure staff really understand how the mask should be placed on how it should be located on their face. Let's see. You're using one pair of gloves and going in and out of rooms with the same gloves touching the mask. So there's no changing of the gloves. Again, we're going from room to room and nobody's changing their gloves or washing their hands. Another thing is, think of your kitchen. No PPE being worn in the kitchen. So remember, the kitchen is an area that whatever they do in the kitchen, whatever those staff do is gonna affect all of your residents in your facility. So that's another thing to think of as far as environmental services to keep clean. How about, you know, when the dietary staff deliver food carts, are they taking and going and putting the food cart in resident's room, COVID resident's room? Are they using this, you know, they're placing it on their nightstand? Are they coming in contact with the resident? Then they come out, they grab the next tray and then they go back into another residence room, the whole time not changing their gloves, and they're going in and out of different rooms. So that's one thing. And another thing is the cart getting cleaned. The cart that, you know, they've touched all throughout the day as they're moving trays, is that getting cleaned down properly between residents and between shifts? And how is, you know, what's that coming in contacting with? Like, another thing is wheelchairs. And if you have a COVID positive resident that needs to go to dialysis, they're going to need to be in a wheelchair to go to the transport. So, you know, that resident needs to make sure they have a mask on, and when the wheelchair is going to need to get cleaned and disinfected. And sometimes you might just, if that resident comes and goes to dialysis, maybe you might want to consider, if there's enough wheelchairs, to leave that in that resident's room, but still you're going to need to clean it so it doesn't get exposed to others. We also saw that dishwashing temps are not hot enough. You know, this is a virus, and you got to have the dishwasher temperatures high enough to kill the actual virus. So we did find that there's problems with the dishwashing temp not being high enough. Let's see. Okay. Remember, you always have to be reporting. I know DHHS has come out with some new reporting requirements, but you need to follow those. We are not the collector of all the information as far as reporting wise. That's all handled through the Michigan Department of Health and Human Services and your local health department. So you need to make sure you're reporting to the correct agency and what you need to report. Now, if you have a resident that has signs and symptoms that's leading to think that they are presumptive positive and waiting for results, you need to make sure and treat them accordingly. If somebody's showing signs and symptoms and you're thinking that you're suspecting that they are positive for COVID, but you're just waiting for the test, you don't want to keep that person in a room or in the same wing as a negative unless you isolate them. If it's a single room and you shut the door and isolate that resident and pending the test results, but you need to take action on what you're going to do with that resident. Let's see. Segregating, you know, it's important to make sure you segregate your staffs or cohorting them with symptoms, non-symptoms. Another thing is to have designated staff. If you have a COVID positive wing in your facility, it's always a great idea, and CMS even talks about it too, that you should assign that person to the COVID wing and have them stay there. Have them work every day there. If you have, and then just keep them there and have somebody assigned to your negative wing. The reason is it's always good to have consistency in this time of frame. If I'm taking care of Mrs. Smith every day, I'm going to know Mrs. Smith. I'm going to become very knowledgeable about her habits, and how she reacts to things. And I'll be the first one to be able to tell you when Mrs. Smith is not acting like herself and she's kind of declined in her status. So that's another reason why it's important to make sure and try to keep staff on their designated wings and keep them assigned to the same people, because that can be very helpful in helping you to identify those residents that are starting to have a decline in their status. Another thing we have seen, facilities, some of you have fantastic infection control policies and procedures, but we're just seeing that they're not being implemented. That is the big thing. We can read it and it's spot on. However, we just don't see it being implemented in the facilities. Again, dietary not consistent with basic infection control practices, and staff call-ins. You know, staff are calling in during this time. They're sick, they're scared, everybody's scared. And but always remember, as part of your emergency preparedness plan that you had in place, it should address how you're gonna handle those staff call-ins as far as, you know, agencies. And I know that's even hard right now, but do your best to get staff in during this time. These are just some, like I said, some of the basic things that we have seen as surveyors, observations when we've been on site. As you know, we go observations, interviews, and record reviews. And from what I've talked here, most of these are just plain observations. And there are three, I know right now you guys are getting inundated with documents to read and everything. But we have shared these with you, and I would highly encourage you to read them. One of them is the COVID-19 long-term care facility guidance. It's dated April 2nd. There are 3 pages, but let me tell you, there are 3 loaded pages of information here. They have different things highlighted. It's just a very good, useful document. I'm using it on a regular basis. The other document is the QSO 2020 memo. It talks about us doing these infection control surveys. It also talks about the halting or the suspension of all of the enforcement action that was in place. This question has been coming up several times that I was in denial of payment for new admissions, the DDP&A, and I want to take in residents now during this COVID pandemic, but I'm afraid since I'm in denial of payment for new admissions that I can't. Always remember the memo 2020 halted all enforcement actions. So if you were in denial of payment then, it's stopped, it's been halted. So you are free to admit residents and they will be paid for during this COVID period of time and after. But that's one of the things, this memo, this 2020 has all that information about the halting of the enforcement action. And also at the back of that, there is the COVID-19 focused survey for nursing homes. What it is, it's the checklist that our surveyors are using when we come on site. According to the 2020 memo, CMS is asking you as a provider to fill out that questionnaire on your own, is do a self-assessment, and you're supposed to be turning it into your health department. And this is also when our surveyors come on site, they're going to ask for the same document to see if you've done your self-assessment. So I highly encourage you to do that. Also, when you do this self-assessment and complete this questionnaire, it's got a wealth of knowledge just in itself. So that's another document that I have been referencing, and it's, like I said, it's got a wealth of information in there. So I highly encourage you to these 3 documents, the 2020 QSO memo with the focused survey nursing home checklist and the April 2nd, 2020 document. Both those 3 documents are the ones I am referencing a lot and copying and pasting sections of them. It is just a wealth of information. And, you know, it talks about, the one section even talks about if there's COVID transmission in the facility, healthcare personnel should wear full PPE for the care of all residents, irrespective of COVID diagnosis or symptoms. So this information is well written, it's very pertinent. So I highly recommend that everybody, if you get a chance to take a look at it, tab it, highlight it, whatever you find is useful for as a go-to, but it's very good. That concludes my general findings. Again, I would say the top finding we have from what I'm hearing from the surveyors is staff walking from one area to another and not taking off their PPE. So they're going from the positive wing to the negative wing. It's not as bad if you've been working in the negative wing all day and then you go to the positive, but when you leave the positive, you're gonna need to take off the PPE. You can't do the reverse. But always, that's the biggest thing we're seeing is that staff are going from one wing to another and not taking off their PPE. They're going one room to another, not taking gloves off, not washing hands. That is probably some of the biggest thing that we're seeing right now. So with that, I'm going to turn it back over to Mary for the question and answer.
Thank you so much, Michelle. All right, at this time, we are going to open up to questions. You can unmute yourself to ask a question. Please make sure you mute yourself immediately after you're done asking. You can also type a question in the chat and I will read it out. We do have one in the chat already, so I'll go ahead and ask you this one, Michelle. If a resident develops symptoms, should they be presumed positive and moved to the COVID unit until swabbed and results are back?
CMS, if you look at the April 20th guidance, CMS's ideal situation would be a negative wing, a transitional area, and a positive, because they might be having signs and symptoms. So you don't really want to keep them in their negative area, but yet they're not confirmed positive. Yes, they're showing the signs and symptoms. That's where that transition area, if you could have an area of your building, and if it's feasible, to have a transition area so that you're not keeping them with the negatives, but you don't want to put them in the positives if the test comes back negative. So you want to keep them in this transitional area away from both. And CMS talks about that in that April 2nd document on page 3.
Thank you. Does anyone else have a question? We have another in the chat. Are we to remove masks when leaving the unit as well?
That is, are we talking the surgical masks or N95s?
Etta, do you want to clarify? Etta said both.
Because I know there's, surgical masks are easier to come by than the other. If there's supplies, it would be best to take off. I mean, that's all your PPE, take it off and put it back on. That would be the best. But, if you can't, some places are even thinking of trying to put a surgical mask over their N95 and then just removing the surgical mask as they leave, because of the surgical mask is actually kind of shielding the N95s. So that makes it, but I know it's hard to breathe when that's happening. But that would be the ideal, is to don off and then go to the other section. But like I said, if you're working in the negative area all day and you go to the positive, then you can transition to the positive is okay. In fact, we've been talking to our surveyors. When you get in there, go to the negative area first. You got all your stuff on, those individuals are negative, and then you transition to the positive, they're already positive. So that, but the vice versa is not.
Great. Another question we have is there any guidance on the governor's $2 per hour increase, and who does that apply to?
I cannot speak to that. That's all handled by DHHS, or maybe the LEO, which is the occupational division, or the occupational bureau within Laura, but we don't deal with any of the money and the dollar an hour, raise or anything. We don't have any say in that, so I can't speak to that.
Okay. We would like some more clarification on the 3 units. If a building does not have the capacity to have 3 separate areas for negative, positive, and transient, whatever you want to terminologize that, how do you want that to be handled if they can't do that?
If they can just isolate, if you have a resident that's is showing signs and symptoms, you don't know if they're positive or negative. If they have a private room, just shut the door and isolate them. That's something as simple as that, and make some note on temporary isolation, or make some note on the outside so people don't just wander in thinking, okay, Mrs. Smith was, for the last 2 days, she's been fine, and now Mrs. Smith's got some signs and symptoms of COVID. We're just going to keep her in the room, but make sure to, notify or put something on the door to alert, precautions, isolation precautions, so that people, when they go in, they know that Mrs. Smith, they are prepared in case Mrs. Smith is positive and have the proper PPE. So if you can do that, that's better than putting them in a separate area. But if you can just isolate them into a room, that would be fabulous.
What if they are in a semi-private room? Do we move them or keep them together and test both, or how do you handle that if they're in semi-private?
I think Kathy and I were just talking about this. I think she's trying to get clarification from the MDHHS EPI on how to handle those when they are sharing a room. Do you actually take, since one is showing the signs and symptoms and the other one's not, on how to handle those. Another thing to do is to reach out to the local health department and ask them how they should be handled.
Hi, this is Kathy. Michelle is correct, and that's one of the things that we are working with MDHHS to get some guidance on, because CDC currently does not have clear guidance in regards to handling individuals who may be asymptomatic and testing positive, or when you've got two individuals in a room together where one starts showing signs and symptoms but the other does not. So I would echo Michelle's thoughts and get your local health department involved in those decisions. And in the meantime, I can share that MDHHS is trying to work with CDC and get some guidance that we can get out to everyone. So I hope that helps.
Another thing, if I might piggyback onto that one, is we've been getting a lot of emails into our the Laura helper email box regarding residents in locked or demented units or locked units, or how do you handle those? Because we all know a lot of the demented residents do not want to wear a mask. And so in those and we don't know the layouts of every building. So in those cases, it's best to contact your local health department. They could probably send somebody in there, and maybe they can do testing on the residents in the demented unit to see maybe they're all positive. We don't know, but ask them for guidance on that, because we don't know the makeup and the configuration of all your buildings. And I know it's difficult if you have a demented resident who's positive for COVID and they want to wander and they don't want to keep a mask on. So that does pose a huge problem. So it's best to reach out to the health department and ask them for guidance. They can assist you in giving you some ideas of what you might want to do.
I have a suggestion. You might want to put a happy face on the mask when you're going into a memory care unit. It might make them happy.
If it works, it works. But yes, just work with your health department to see if they can offer you some guidance or assistance in all of that. That's another thing. Like when you are, if a resident is going out for dialysis or things such as that, in the document, the April 2nd document, it says that they should always try to have a mask on, or staff. If your staff members, your seniors are going in to help a resident, it's always a good practice for the resident to even take a tissue or something and make sure they cover their mouths, so that way it can help both ways, the staff and the residents, to help contain the spread.
Okay, another question is, if the whole unit is positive, do the doors to the residents' rooms need to be closed? And do we need signs on each door that alert people that the room is in isolation?
I would put a sign just as a precautionary thing, even though it's all positive. One thing to do about the closed doors, remember aerosolization procedures. And there was a document DHHS put out, I think we sent, that tells what kind of PPE you need to have, or what kind of mask. Aerosolization procedures, like your nebulizers, those are aerosol producing. And even though it's probably best when you're doing those types of procedures to have the door shut, to just help to contain, because we've all heard the virus lives, 3 hours in the air. So, somebody's mask might not be fitting just as well as somebody else's mask is. And I think it's a good precaution if you're doing those types of procedures that are aerosol producing, to make sure the door is shut and do those procedures and keep the door shut so everything settles back down before you open it up again.
Great. How do you determine when surveyors go into a COVID positive facility for survey or sit in the parking lot?
They are all to be going in. Our surveys, as most of you know, we have to do on-site observation. So somebody has to go in and do the on-site observation. Some of them will be doing the record review via the parking lot in the car with access to the access to your systems. So but all of our infection control surveys, we have to go on site in the building to perform the infection controls. We have to do our observations there. We try to limit our amount of time that we are physically in the building. So we will do our observations, and then we'll call staff. I know today that's part of interview, it's observation, interview, and record review. So sometimes we will actually, the surveyors might even ask you for staff that are working and phone numbers, so that way we can do our part outside of the building, so we have to limit how long we're in. If you look at that QSO Guide 2020, that QSO memo, and then I talked about in the back is that checklist. There's also a summary page that tells what kind of activities we do in the building and what kind of activities we do outside of the building. So you can look at that, reference that. That kind of explains a little bit more what kind of things we need to do inside and what things we can do outside. But we're trying to limit the exposure of the staff in the building. So we have to go in though to do our observations and interviews, but one person might go in, some teams send in both, and then they get it done. They in there, get it done, and then they do the record review part on the outside.
Great. How do we prevent a citation related to social distancing if residents on a memory support unit are encouraged to use safe social distancing, but don't comprehend even with ongoing direction, are offered and encouraged to wear a mask, and are assisted with frequent hand washing along with detailed care planning? Surveyors left with this concern.
That's a tough one, because we all know that those residents are they don't like to be in their room. They like to wander and socialize, and you can do the best you can. That was be one I would also probably reach out to your survey team manager about, and just ask for their guidance. And don't be afraid. This is a good time too, to reach out. Your survey team managers, they're human beings too. They are a wealth of knowledge. Reach out to them before it even gets to the survey part. Just say, hey, I'm having problems with this. What do you suggest? Those are always things, but in that case, I would actually reach out to the survey manager, because that's, like you said, they like to wander. They don't like to wear masks. They're, it's a difficult population.
Great. Another question is, the health department states that we can allow COVID positive staff to work, but they must work on a positive unit. What are your thoughts on that?
If that's the direction the health department says, then that's the direction the health department, it makes sense. I hear that that's being done in the hospitals if they have signs and symptoms of COVID, but yet they're not feeling that bad, that they can go to work in the positive. But I would follow the direction of the health department.
Okay. Is there some kind of guidance going on with surveyors to keep the surveyors either to strictly positive facilities or strictly negative facilities to try to keep facilities safer? Some of our buildings are not allowing staff, physicians, et cetera, in the building if they've had any contact with a COVID positive or PUI in the last 14 days. Are we able to follow that policy with surveyors as well to make sure that they're not transmitting things into our buildings?
The surveyors we are presuming that every building they are going into is COVID positive. We're taking that approach that they're COVID positive, and our surveyors are going in with the proper PPE. They all have new fresh PPE for each building, So they're putting in PPE. They're going to be wearing PPE while they're in your facility to prevent the transmission from building to building to building. So we are required by CMS, we've been directed by CMS to perform these surveys as long as we have the proper PPE, and we do, so we are to continue to do the surveys. But yes, they are approaching every building as if it was positive.
Next question I have is, when surveyors see staff violating isolation protocols and move from COVID to a clean unit, how many instances of this would a survey team allow before alerting the site? This is obviously an IJ situation, but it's also a public health emergency, and this practice is critical. Note it, notify the administrator, and move on, but don't just watch and let it happen numerous times. Is there a protocol in place for that?
We've always, whenever we do surveys, I'm always been a firm believer that if I see something happen once, I have a tendency not to cite it, but I want to see if it's a reoccurring. So the surveyors will watch, and they'll, during their observations, they will they're all eyes watching to see if it's a one-time isolated thing or if it's everyday, if it's happening over and over, and you see numerous staff do it, and that is a concern.
Another question I see is, are you going to be visiting every building?
It is the goal to, well, let's put it this way. We are doing, we're doing buildings, and right now CMS has suspended this regular survey activity. So we're going to keep doing these infection control surveys until we're directed not to continue, until we're directed to stop, or until CMS tells us we need to resume our other survey activities. So there is a possibility. We have 450 some nursing homes. We have a few to do, so we'll just keep plugging along.
Okay. Another question I see is, if you are not doing AGP on a COVID unit, can the doors stay open?
AGP, what is? What's AGP?
Hey, it's Kathy. That's aerosol generating procedures.
Okay. If they're not doing those procedures, I don't see why you can't have the door open. It's just, if you've completed the procedure, like I said, the aerosol, it can be airborne for 2 to 3 hours afterwards. So I would wait a couple hours after you've done the procedure to open up the door. But yes, if you're not doing any procedures and the residents just laying in their bed, watching TV, there's no reason why you have to have the door shut. Definitely have the room, label it as, an isolation, just so everybody's alerted.
Another question I keep seeing is, how can you issue an IJ from the parking lot without entering the facility?
They have to enter at some point to do the survey. I know at one point, I think we tried doing more of a Skype type. Mr. Horvath was trying to experiment with Skyping, having the provider go through the building and just, like FaceTiming type things. But we have to, CMS has directed us, we have to go inside. So, there had to have been some observations. Like I said, I don't want to talk specifics, but if somebody wants to reach out to me offline by email, I'd be happy to see I'm trying to get a clarification of what facility and what exactly was the instance.
Do we have any more questions from the audience?
Will facilities get 2 or 3 surveys, or it'll just going to be 1, and then if you passed it, you won't get another one?
Right now, the direction, if you look at that 2020 memo, we are to do IJ investigations. That's our top priority, and we have to do the infection control surveys. So we might have, if we do an infection control survey on you And then 2 or 3, 4 weeks later, we get an IJ complaint. We have to go out and do the IJ. We have to do the IJs. That's been that's actually the top priority, is we do the IJs, and then while we're there, we do an infection control survey. But if we get an IJ and it's an infection control issue, we have to go back out. So there could be a possibility you get surveyed again.
Thank you.
Another question I'm seeing is how many citations have been given out since the start of these surveys?
I have not kept track of that. Like I know there have been a few IJs, and the big thing is the staff going back and forth between units, in and out of residents' rooms without using hand hygiene or changing gloves or all of that. That's the top offenders.
Kathy, are we tracking that at HCAM?
Yeah, we've been pulling data as it's available. A lot of it has not been available up until recently.
Okay.
I have a question regarding the statement on all staff wearing full PPE. What, by all staff, do you mean like the business office, the central supply, and do you mean goggles, mask, gown, gloves?
I would refer you to, in essence of time, I would refer you to the April 2nd, 2020 guidance, and also the checklist. Both of those address that, and to make it clear exactly what they're saying. But me personally, I wouldn't think that somebody working in the office and never going out on the floor at all, I would maybe think a mask, but you know, you'd have to read those guidelines for sure.
How does the state survey process intersect with, or not, the IPRAT process?
That is a good question. I think the IPRAT again, that's through DHHS, but I can just tell you the little bit that I know is, as you know, our infection control survey started, the 2020 memo came out on March 23rd. So we've been doing surveys pretty much a month now. And the IPRAT, I think I've seen they have a checklist, or a little checklist similar to ours. So I don't know how much of a duplication it is. I don't know if it's just going to be a verbal, they'll call you and have you go over it. I'm not sure how their process is. And I don't know if they've totally ironed it out yet, but there is a DHHS email box that you can reach out to and ask questions. I think they're manned a good portion of a 24-hour period. So you could reach out and ask that question. Like I said, I can only speak to what we have. I do know that there is some discussion. There might be some little bit of overlap, but I would just reach out to them for complete guidance.
Okay. Another question came through. I thought the QSO also indicated there would be desk reviews completed for Fry's. However, I understand that the survey monitors are still screening and holding for survey visits later on. Can you please clarify? We cannot go on site and do desk reviews, or go on site and do revisits. So according to the SOM, if you have a citation of an F level or lower, and the F cannot be substandard quality of care, you can, a desk review you're eligible for a desk revisit. And our letters going out will say if you're eligible for a desk revisit. And it will also say we've changed our notices that go out to include what you would need to submit for the desk review. Now, the Fry's, some of those, the surveyors, some of the managers will check them off. Some of them like to keep them.
and they'll just, you know, look at them possibly when we're on site, when we go back on site. But you know, as everybody knows as well as I do, that, you know, you're still reporting your fries, and Michigan has some of the highest fries in the nation. So when this all gets lifted, it's going to be very interesting to see how CMS handles all this, because we got to think, we've got all our surveys backing up. We have all the level 2, 3s, and 4s complaints backing up, and we have all the fries backing up. So I have no idea how CMS is going to handle all this going forward. But to answer your question, there's something there the manager must have wanted to keep it there for when we do go on site.
Okay, another question I got is the CDC issued the Infection Prevention and Control Assessment Tool for long-term care facilities. Is this only to be available for a health department visit? It differs from the self-assessment that is part of the CMS 2020.
I can only speak, I mean, I just go by what CMS has issued. Your facilities are Medicare and Medicaid certified, and I have the CMS guidance. I cannot speak for what the CDC has put out or the other guidance. I can just speak on what we have from the CMS. And if you look at the CMS checklist, it does say a lot of it must be, because they talk about CMS and CDC, so they do work together.
I have a question regarding the health department's universal testing of all residents, even our asymptomatic ones. So how can a facility cohort an entire building timely once those results are back? What would you consider that timely cohorting when they do the massive test of everyone in the building?
Well, you know who's in your building right now. If you probably have a COVID area, and you probably have a negative area, correct?
Yeah.
Okay. You have your little transitional area.
We do. I think the challenge is that we get all the results back at once when they test everyone, including asymptomatic. So how would we approach, or what would you consider a timely separation of these residents between the ones we didn't even know what it were? What would be your recommendation?
Well, my recommendation is, as soon as if you're able to show that you got the results at, say, 9:30, at 9:45, you started seeing these and you started doing the moving process. I mean, that's as soon as you can. We don't expect you to have everybody moved within 15, 20 minutes, because it takes some time. But if I got the results at 9:30, at 9:45, we've moved this one, you're showing that you're moving them as fast as you can to to cohorting them appropriately. That's the best we can ask of anybody. We don't expect you to move them in 15 minutes, because you got a lot of things to move. So do your best, but don't, some things, if you sit on them, you get the results at 9:30 in the morning, and 2 o'clock in the afternoon, you haven't moved a single soul. Well, that's a little concerning. But, we don't expect you to move them in 15 minutes. But if you get the results, I would start working on it as soon as you can. And then if there's any questions, you can say, hey, yep, I got the results. I started moving this one at this time, and we've been moving ever since. I mean, what more can we ask of you?
Okay, another question that we got is, what are the consequences for not reporting COVID cases in the facility to the county, state employees, and families?
I cannot speak on the health department. I know CMS came out with that directive that I haven't even had a chance to read that memo. They did come out that you're supposed to report to staff and family who the positive people are. That could land you a citation for sure.
Okay. Another question is, we are eligible for a desk review. How long is the wait before we contacted if the desk review was approved? We are currently 6 weeks out from the date of compliance.
Remember that all enforcement action has been halted, and the survey managers are doing their best to be timely on those, but there's a lot of things going on behind the scenes that they might be delayed. And you know, some of the managers are doing first in, first out, because we're trying to get them, and they have to review all those documents, so that does take some time. But they should at least tell you that it's been received. And like I said, all enforcement action has been halted, so you got your date of compliance, it's there, but like I said, the enforcement action's all been halted, so it might take some time.
Okay, another question is, how are facilities notifying families and staff of new COVID-19 positive patients and or staff?
That's up to your facilities, how you want to do that, but the guidance says you have to notify them. So like I said, I haven't had a chance to read that yet. You have to notify them. I don't think CMS ever gets that specific on the method of how you notify anybody.
The next question I see is, if your facility has been IFC site free for 3 years, are you exempt from the IFC survey?
No.
The next question I see is, the health department instructed the PUI and roommate to stay together, as they said the roommate should be presumed exposed, yet surveyors cited for doing what the health department and physician instructed.
There might be more to that. Like I said, I don't want to get into details of a particular survey. If you want to reach out to your team manager regarding that, because I can't speak on what was there. I mean, there's something else there's a piece that's missing, so I cannot speak on that.
Okay. I also have a question. What have you heard about possible timeline connected with the upcoming guidance QSO-20-56-NH?
I have not read that one yet. I'll have to take a look. So I guess right now I cannot speak on that one.
Hello, can I ask a question?
Sure.
Okay, we have to let the state know on a daily or weekly basis, I think, about the number of COVID patients we have in the facility. So the state already knows what our facility is doing. Can't we refer the family members to that site that will show them, instead of us, calling them individually and letting each family member know? I mean, they can go to the site and see what's going on.
I understand what you're saying. That'd be a question that I can reach out to CMS and ask. But right now, I would definitely come up with a plan for yourself and for your building to make sure everybody's notified. But I can reach out to CMS and then ask Kathy.
Right. I've had several conversations with the media, and you might see me on TV today. My name is Charles Dunn. And basically, they all are hungry for that information too. So you can go to Channel 7 and click on whatever that they tell you to see which facilities have the most and the least number of cases. And as a matter of fact, there isn't a nursing home in the state, I don't believe, that doesn't have at least one. If they don't, then they're not testing properly, because I can't believe that nursing home has zero. But if that's the case, good for them. But I mean, the public should know. But I just don't think it should be. We have to spend the energy on calling all the families, because when the surveyors come in, they're going to want to see some sort of proof that we did this, it's like really cumbersome.
I understand what you're saying, but I think there has to be, like I said, I haven't had a chance to read because I've been on conference calls after conference calls. But I have to go back and look at that document. Does it say that they have to identify the residents? So like if I'm a CNA working and we just found out that Mary Smith is positive for COVID, I have to be able, I should be told Mary Smith is now positive for COVID. So I think there's going to have to be some name exchange internally. But like I said, I haven't had a chance to read that memo.
Well, you're a very busy lady, and we appreciate everything that you're doing.
Well, thank you. I wish I could, I would rather take care of things like this than be on conference calls all the time. I mean, there's days that it's just nonstop, and I know you guys are busy too, but I would rather work on this stuff than conference calls.
Well, you know, just a little clarification on this would be helpful, because I wouldn't want the state come in and give us a citation because we didn't let all the families know about how many COVID cases we have in our building.
Okay, yeah, I will reach out to CMS and ask.
And thanks a lot.
No problem,
All
thank
right.
you.
We are past 4 o'clock at this point, so we are going to cut this off at this time. Thank you everyone so much for participating. If you have further questions, you can always send them to the team at HCAM, and we will try to get answers for you. But at this time, we just want to say thank you to Michelle for joining us and for having this great discussion. Thank you, members, for joining us as well. I hope you all have a great afternoon.
Thank you.